Thank you for the invitation to speak today. I'm really happy to be here. And I think this is the most important session of the World Conference. Everything starts with staging before treatment. So I'm Dr. Louis Gros. I'm coming from Lausanne University Hospital, Switzerland, one of the best countries in the world. Also, yesterday we had a slide about Switzerland on cost effectiveness for screening, comparing annual and biannual screening. I think Switzerland can afford annual screening. That's first point. So, TNM. So the first question is, what is TNM? So the TNM classification is a standardized system used to measure the extent of cancer and to estimate its prognosis. And here there are two key concepts in this sentence. First of all measurement is an approximation. This is a very important thing that when I was all my life 1 meter 83, then I moved to America and then I became 6 feet. And if you do go back to the meters, then 6 feet is actually 1 meter 82.7. So I shrink during my time in America. So all measurement is an approximation. I even look at yesterday night, how is 1 meter defined? So it was defined after the French Revolution. They decided to start to do things scientifically, and they decided to use the distance, so 1/10 millionth of the distance from the North Pole to the equator, passing by the Paris Observatory. And they really send people to measure that, and they come out with a platinum bar, and they decided, okay, this is 1 meter. So, and right now, 200 years later, we change. Now it's the speed of light who defines distance. But just to say that all measure is an approximation. And when we talk about prognosis, so what we want with the staging system is a likely outcome of a disease regardless of treatment. It's just to see what's probably gonna happen, and we need it to be the best possible so we can make the best possible choice for patient. Those are the milestones in the TNM history. It started once again in France with a surgeon named Pierre Denoy, who in Gustave Roussy, he was a surgeon for breast cancer, and he was the first one, at least, to come out with the idea of a TNM classification. And since then, the first official publication was in 1953. And another major step was in 1987, where we decided to unify staging system between the Union of International Cancer Control and the American Consortium for Cancer. This was a good step. And since then, as you see, every 2 or 3 years there is a new version, and now we are on the 9th edition, effective since January. Sorry. So what this slide showed us is that staging is a perpetual change. And we know that change is not easy, and there is two key questions when we think about change. Why is transformation so exhausting? Because we don't like to change. Change is hard. And how do we fix it? I think we can fix it by really redefine what we are trying to do. So we want to have a better staging system because the purpose of it is to cure more patients. We want to be able to have better data to cure more patients. So we need to go all in development, and I see that ISLC is working very hard. I think we need to invest our money in people with the right capabilities. I think we need to all be able to change our mind. It's a very important thing. And those kind of conferences are really important to exchange ideas. And I think one other point I want to make is we need an inclusive leadership, because a lot of people here in this room have a lot of responsibilities, but I think new ideas to progress can come from anyone. Okay, this is the ISLC 9th edition. So the limitation from a medical oncology standpoint is that the TNM is mostly based on anatomy, so and not on biology. And this is the question mark that we have now is, should we incorporate molecular marker? Should we consider pathological indices? And should we consider even the tumor microenvironment? Then I am a medical oncologist and I did a fellowship in radiology. So I start to be very interested in the radiological criteria, as we see that they don't believe all the same, non-solid, parasolid, or solid nodules. And then as I see patient, I think it's sometimes crazy to stage a patient with 32-year-old the same way that you stage an 86-year-old patient. So why change? I think we had a lot of people want to change. This was a question which was asked in the ELCC 2022. It was before the last edition, but to a crowd of experts, when the question was, are additional refinement needed to better the TNM staging system? 100% of people said yes. Should some of the biological features be incorporated? Yes, 86%. And should molecular alteration, such as EGFR, KRAS, ALK, be incorporated? Yes, it's a smaller yes, only 72%. Here I put some data to illustrate how many of those targetable alteration we can find only in biopsy of those small lung cancer. It's a very nice article if you want to read it. So why change? The problem is the missed risk. So if we consider a patient with a 31 millimeter lung adenocarcinoma, KRAS mutant, the question we have as medical oncologists is, should he get adjuvant treatment? Because we know we have pretty good data, notably a review of 482 patients with pathological stage 1 and 2 with no lymph node. And it's a study from Memorial, and they looked at the overall survival at 5 years, between the difference between KRAS and KRAS wild type tumor. And we see that KRAS mutant tumor have a way less, a worse overall survival than the KRAS wild type. There is also a risk if the staging is not perfect. There is also a risk of overtreatment, because non-solid cancer, as we've seen, are a very special category, and I think we can safely say that they deserve their own staging system. There is other biomarkers that exist that have been studied, for example, PD-L1, which is this protein on some cells, notably cancer cells, who can help hide from the immune system. PD-L1 is not such a good prognostic marker, but we have also other interesting data from the tumor microenvironment. For example, we looked at, a Norwegian team looked at the density of very special white blood cells, which are named CD8, and they looked at how many of them were present near the tumor, and this could help stage the tumor better. I'm gonna finish very fast. I'm just gonna say that there is gonna be more and more options available for patients in terms of personalized medical drugs, but also in terms of immunotherapy. And in this area, it means we need a better and better staging system. That's the only thing we need to learn. So the goal of the staging system is to improve the outcome of the individual person, and in the same time, we need to establish a universal standard of quality to build the next generation of studies. So I'm going to finish here. Thank you very much.